Welcome to the American Academy of Optometry Foundation's clinical podcast series, brought to you by the Primary Optometric Care Channel. Today's topic, effect of low concentration atropine eye drops versus placebo on myopia incidence in children, the LAMP2 randomized clinical trial. Today's host is Brujic, the topical editor is Chelsea Bradley, and today's topical expert is Michelle Mann. Now, on with the show.
Hi, I'm Dr. Brujic. Thanks you for joining us for this episode. We're currently joined with Dr. Michelle Mann, who's going to be talking a little bit about atropine and myopia progression management with children. But before we jump into it, Michelle, give the audience a little bit of a background on yourself.
Sure. Thanks so much for having me, Dr. Brujic. I am originally from California, went to Berkeley, and then did a residency in cornea contact lens at the Illinois College of Optometry, where I'm currently an assistant professor, and I also work at a private practice at North Suburban Vision Consultants, where I'm fitting a lot of advanced contact lenses and doing quite a bit of myopia management.
That's great. So we're going to be talking about a topic that's right up your alley here. The article is the effect of low concentration atropine eye drops versus placebo on myopia incidence in children, the LAMP2 randomized clinical trial. Michelle, tell us a little bit about the study design and what makes this a little bit different than some of the other myopia management clinical trials.
Sure. So I think this one was really interesting because most of the other studies that have been done were more looking at slowing down the progression of myopia, but this is the first randomized control study that actually looks at the incidence of myopia and seeing if low-dose atropine can actually prevent the onset of myopia. So they split about 474 subjects into three groups. So they were either given a placebo, a 0.01% concentration of low-dose atropine, or a 0.05%.
How old were the kids that were enrolled in the clinical trial?
Yeah, good question. They were 4 to 9 years old.
And did they have to have a certain refractive error to get recruited into the trial?
Right. So they couldn't have myopia yet because that was the whole point of this study. So anywhere from plano to spherical equivalent of +1.
Okay. So they're hovering close to that zero mark, essentially.
Right. And they did have one parent who was myopic, who was at least -3. And so they looked at over 2 years, was there an increased incidence of myopia? And compared to the placebo and the 0.01%, the 0.05% group was actually the one that was statistically significant for a lower incidence of myopia, but also a lower rate of what they called fast progressors, which was increasing 1 diopter over those 2 years.
So the bottom line, Michelle, is 0.05% atropine in children that are essentially deemed at risk cut their chance of progressing into myopia over that 2-year time period significantly less than either of the other two groups. Is that kind of really the gist of the discussion?
Right. So they were seeing if it was going to be preventative. I think because it's only 2 years, the authors did state, maybe it's just a delay, but it definitely made a significant difference. And so it's something that we can now offer some of those parents and children, rather than just talking about that outdoor time, to say, maybe we can consider this low dose treatment.
I was just about to ask you that question, Michelle. How, as a clinician, what are you doing with this information, and is it changing anything? And have you already seen patients where you are maybe implementing these changes?
Yeah, that's a really good question. I think it's definitely something we can add into our toolbox. I know a lot of my patients who have siblings, older siblings who might already be in myopia management modality or treatment options. Their parents who maybe they have both parents are myopic, and so they know the effects of high myopia. They're saying, okay, my younger child, if they are hovering, like you said, around that plano hyperopic, and we know that based on their risk factors, they're probably going to become myopic. Now we can actually offer them something.
So I guess the next question I have is, just from an overall perspective, if you were to get some take homes from this clinical trial, what would you recommend to our colleagues as some take homes from this clinical trial, and how it might modify the way that they manage these patients?
I think one of the big things is looking at what concentration we're going to do if we are going to treat with low-dose atropine. 0.01% was not shown to be statistically significant. And similar to their previous study, the LAMP1 study, they didn't see that there was much of an effect. And so maybe if we're preventing myopia or delaying the onset of myopia, but also slowing the progression of myopia, considering maybe a higher concentration. And the other thing is just keeping up on the literature, because hopefully the group that was being studied, they are going to be going through 6-year trials. And I know there's a lot of new information that's coming out. So being able to provide that to our parents and patients who are asking.
And I know that one of the questions that parents will always ask is, well, what's the adverse effect? Like, what's the, if I use this drop, we don't necessarily know if my child's going to become myopic, but everything's pointing towards them likely becoming myopic. But if we use this drop, what's the adverse event profile? Did they look at that at the study? And if so, what did that look like?
Yeah, they did. So they kept it mostly open-ended. There were a few specific questions about glare and visual acuity, but the most commonly reported side effect was actually photophobia. But what was interesting it was very similar between placebo 0.01% and 0.05%. And so I think the adverse effect safety profile wise, it was something that was not too adverse, that a lot of patients actually did not drop out.
I'll tell you, Michelle, it is interesting, like even how much this is totally reshaping the way that we talk to patients. I tell adults all the time, if I was seeing you today and you were either at risk of becoming nearsighted or you started nearsighted progression, I would treat you totally different today than when you were a child and you were seen, because everything's changing. We can slow the rate of progression.
Yeah,
and
definitely.
It's amazing how their eyes light up, because a lot of parents still are, from a larger perspective, they're unaware that we can influence it. I still think a lot of parents think that the only way that we can treat these people or treat the kids is to correct them. And that's kind of it. And it's just advanced so much. And the data that you just shared is one of the evolution of this information, this knowledge base that we have.
Right. Couldn't have said it better myself.
Well, Michelle, thank you so much for being on this episode of the American Academy of Optometry Foundation podcast series.
Thank you. It was a pleasure.